Good morning, everyone, and it's a great pleasure to be among our teachers and also with such an esteemed faculty. The remit of, first of all, I need to say when Professor Agarwal says you do this, you jump to this occasion, you always follow the instruction. And again, his remit for me was to discuss clinically useful advances in the lymphoma. So with the interest of time, what I thought I should do, Kalpesh, can I move them? What I decided to do is to highlight these topics: diffuse large B-cell lymphoma, Hodgkin, peripheral T-cell, follicular, and CLL, where we have seen practice-changing advances in the last 5-6 years. In 2020, when we use the word diffuse large B-cell lymphoma, the few things come to our mind. The first is R-CHOP still the standard of care? How do we identify different risk categories in the diffuse large B-cell lymphoma? And what is the role of consolidative radiotherapy? And the most important question is, with the understanding of the cell of origin, have we made a difference with different small molecules adding to the R-CHOP platform? I thought we should take this opportunity and run a little bit with the history and then identify where we are. Now, going back to 1993, we have a data from the American study with Fisher in over 400 patients comparing CHOP to the different treatments. And what this study did show is there is neither a progression-free survival nor an overall survival difference between either the CHOP or more dose-intense regimens until Bernard Coffier from the JELA group presented the role of rituximab in the diffuse large B-cell lymphoma. We didn't had much progress. After that, R-CHOP had remained the standard of care. And in the last 10 to 15 years, we have been looking at various ways of whether we can make a difference in the frontline study. The UK NCRI group in UK and Australasia conducted the R-CHOP 14 versus 21 trial in over 1,600 patients between R-CHOP 14 and the 21. Again, in this study, R-CHOP 14 was not superior to R-CHOP 21. The way I interpret this data is they're equivalent, and if somebody needs to complete the treatment at a shorter duration, we can use R-CHOP 14, even though there was a slightly increased toxicity. Then, based on the significant phase 2 data from Wyndham Wilson, Kevin Dunleavy, there was a lot of expectation on dose-adjusted EPOC, but the Alliance study comparing the DA EPOC versus R-CHOP again did not show any benefit over the R-CHOP. As far as I'm aware, there's only one ELISA study in which patients who received RAC-VBP along with some dose intensification and consolidation, there is a 14% improvement in the progression-free survival at 3 years, and also just under 10% improvement in the overall survival, suggesting this is the only regimen which has shown a superiority over current standard of R-CHOP. Because of our understanding of the cell of origin, both from either side of the Atlantic and US, we have studies where we looked at the introduction of agent like the bortezomib, and also in the remodel study, and then ibrutinib in the Phoenix study. Again, this addition small molecules into the R-CHOP backbone has not made any difference to the outcome. So what we can conclude in 2020 for unselected patient with a diffuse large B-cell lymphoma, R-CHOP still remains the standard of care. But based on the phase 2 data, we can also say that people with a high IPI 3, 4, or 5, there is a role of delivering the escalated chemo either in the form of R-Podoxem or IVAC, which may offer better overall survival. But only thing is we don't have the data of phase 3 data to confirm it. There is a lot of conflicting data looking at the role of consolidative radiotherapy at the end of the frontline treatment. And we had this recover trial, which they compared two different studies in which for a PET negative patient based on an initial bulk from their definition of over 7.5 centimeter, the consolidative radiotherapy did offer not only overall survival, not only progression-free survival, but also overall survival advantage, even though this was not confirmed in a different randomized study, optimal, but based on this evidence, my practice is still to offer consolidative radiotherapy at the end of first-line treatment in a PET negative patient if the initial bulk was more than 7.5 centimeters. This was in the first line. What happens in the third line setting? Because this is where we have made some progress. The first drug to be approved both by the FDA and by the EMEA is a drug called pixantrone, which as a third line treatment as compared to standard of care, which is predominantly single agent gemcitabine or gemcitabine and rituximab, progression-free survival advantage of 5.7 months and an overall survival of 7 months. To this group of patients, Professor Lorishan et al. Did a study of over 113 patients in a phase 2B setting, looking at addition of polatuzumab to the bendamustine rituximab. After a follow-up, median follow-up of nearly 2 years, overall survival in the patient who are receiving Pola-BR was 12.4 months versus 4.7 months. And I'm sorry about the busy slide, but if you look at the forest plot, it does show that the benefit is across majority of the subgroups, including ABC subtype being benefited by the addition of polatuzumab, and we can say this almost doubled what the advantage we had from the single agent pixantrone. But what has been the most highlighting bit in the last 5 years is the cellular therapy in the form of chimeric antigen receptor CAR T cell. And we do have 3 main CAR T constructs from different pharmaceutical companies: the Axi-cell from the Gilead Kite, Tisa-cell from the Novartis, and Lisa-cell from Celgene BMS, which have been tried in clinical trials and also in the real world data for both from America, Europe, UK. And what it generally shows is the overall response rate is between 50 to 83%. And the most important in this core category of patients, over a third of patients achieving complete remission. And the most important is people who do achieve complete remission having a progression-free survival in excess of 2 years. In the interest of the time, I'm not going into the details of the CAR T, but suffice to say that the CAR T is currently licensed now as a third line treatment. Patient either who are relapsed after an autologous stem cell transplant or who have a salvage and refractory to the salvage chemotherapy and not able to undergo autologous stem cell transplant. Now, what other new antibodies do we have? We have been benefited in the last few years with the biphasic antibody, but the one antibody which has made a significant difference is tafasitamab, which is a humanized CD19 antibody when given combined with lenalidomide. And the lenalidomide is offered for 12 months, whereas tafasitamab is continued until progression. So in this trial of over 80 patients with a median follow-up of 13 months, the overall response rate was 48% and over a third 34% achieving the complete remission, and the median duration of response was 21.7 months, just under 2 years, with a progression-free survival of 12 months. So this is better than what we have seen from the pivotal studies of the CAR T, suggesting that for people who are not eligible to high-dose chemotherapy, autologous stem cell transplant, we do have a therapeutic option. This shows both progression-free survival and also the overall survival, showing real practice changing when we are able to have a wide access to this drug. What I conclude with the diffuse large B-cell lymphoma is in the current 2020, still R-CHOP remains the standard of care. We are not being able to show any of the small molecules added to R-CHOP backbone to show improvement. The consolidative radiotherapy still remains an excellent option for bulky disease in elderly patient who had a size of more than 7.5 at presentation. We do have therapeutic options in the form of either POLA BR for the second, third line treatment, and CAR T is a good therapeutic option as a third line treatment. But the key issue with the CAR T remains the services geared up to deliver CAR T, and also good patient selection, and the most important is the expertise of managing cytokine release syndrome, neurotoxicity, and the cytopenia following the CAR T treatment. With this, I move on to Hodgkin lymphoma, where we have been able in the last 5, 6 years is to look at the role of PET in terms of reducing the treatment in the frontline setting and also escalating treatment in the advanced setting. So we are aware of the both German Hodgkin study group, URTC, and the NCCN criteria for identifying the favorable and unfavorable in the early Hodgkin lymphoma. What the UK group did in over 600 patients is to randomize patients following the 3 cycles of ABVD to have a PET scan in people who had PET negative remission, and the PET was classified as negative based on the standard dual criteria. Dual 1 and 2 were labeled as negative, whereas 3, 4, and 5 were labeled as positive. And here, patients in the PET negative arm were randomized to have either involved field radiotherapy or no involved field radiotherapy. And this showed that there's a respectable progression and overall free survival at 3 years in the PET negative group, suggesting that in selected patients, you are able to omit radiotherapy to avoid side effect. And again, if people are PET positive, 4 cycles of ABVD and involved field radiotherapy also offered a respectable outcome. But where we have been able to have a practice-changing data is from the URTC study, where patients with the early Hodgkin lymphoma with the favorable group have been, the experimental is based on the PET results into 2 cycles of ABVD and having the 2 additional ABVD, whereas PET positive are having the escalated BIACOP. And again, the unfavorable group are having 2 additional cycles of ABVD following the interim PET after the 2 cycles of ABVD, whereas the PET positive arm had an opportunity to continue the standard arm as the ABVD, whereas 2 escalated BIACOP and involved field radiotherapy as the experimental arm. And the data from this study clearly shows that the standard arm, that is the combined modality treatment, is associated with a favorable progression-free survival. And regarding the unfavorable group, it clearly shows that the escalating the treatment from an ABVD, if people are PET positive, has had a better progression-free survival and overall survival at 5 years, as highlighted in this slide. My conclusions for the early stage Hodgkin lymphoma is with our current treatment strategy, we do have high cure rates, and it is possible in a selected patient based on the interim PET scan, we could explore avoiding radiotherapy. And interim PET scan has allowed us to deliver either 2 or 3 cycles based on the HT16 and also the rapid and URTC data to have ABV only chemotherapy only with omitting radiotherapy without having a significant dropout in the outcome, even though for majority of patients, combined modality treatment appears to be the best. But the most important information is for the patient who are PET positive. We get significant benefit by escalating the treatment to escalated BIACOP 2 for the cycles. What do we know similarly in the advanced Hodgkin lymphoma? The UK group conducted the RATFUL trial in over 1,200 patients were randomized following the interim PET scan into continuing either the 4 cycles of the ABVD or bleomycin was omitted, whereas all patients who were PET positive were escalated to either BIACOP or escalated BIACOP, and following the second interim PET received additional chemotherapy if they were PET negative, and if they're PET positive, they were taken out of the trial. And this trial clearly showed in the people who are PET negative, we could successfully drop the bleomycin, significantly decreasing the pulmonary and other toxicity with no change in either the progression-free survival or the overall survival. And what is also came out of the RATFUL trial is people who are PET positive by changing the treatment to escalated BIACOP as compared to historical record. The progression-free survival can be increased to 67.5%. Based on this, I can conclude from the RATFUL trial is interim negative PET scan. It will allow us to omit bleomycin, decreasing the pulmonary toxicity, and escalated BIACOP offered opportunity to improve the outcome for people who are PET positive following the 2 cycles of the ABVD. Another practice-changing study which we have which we have the data in the last few years, is the Hodgkin 18, the EORTC trial, where with the ability of the interim PET, we are able to decrease the treatment. In this trial with over 1,900 patients, where nearly 950 patients were PET positive, whereas over 1,000 patients were PET negative. After the 2 escalated BIACOP, the PET negative patients were randomized to have either 2 further cycles of the escalated BIACOP or 6 cycles. And the study shows with the PET negative patients, by decreasing the treatment to only 2 + 2, that 4 cycles of escalated BIACOP, you are having a 92% progression-free survival at 5 years. And in the PET positive patients, the 5-year progression-free survival is 88%. This clearly raises some questions between the RATFUL and the HT18, in that some patients who have a PET positive even though they do receive escalated BioCorp from the cycle 3, there is still a 20%, 1% drop in the progression-free survival. Based on this data, my practice has been that patients who have a low Hassan-Clover index, the Hodgkin IPI with the Hodgkin lymphoma, I offer them ABVD, interim PET scan, and depending upon the PET scan, either drop to the 4 cycles of AVD, whereas people with the Hodgkin IPI of 4 or more, I do offer escalated BioCorp as a frontline treatment. Now, what have we achieved with adding different agents to the backbone of the ABVD based on the pivotal data in relapsed refractory setting of brentuximab in the Echelon-1 trial. The ABVD was compared to AVD plus brentuximab because of the black box warning saying bleomycin should never be combined with brentuximab. In this Echelon trial, patients were compared between the ABVD and AVD after 2 cycles based on the scan. They were either continued to AVD-A or ABVD. If patients had a dual score of 5, they would continue either in the same regimen AVD-A or ABVD, or allowed by the physician choice to change the treatment with a modified PFS. There is a definite statistical advantage of having the brentuximab added to the AVD arm with less toxicity. Only the peripheral neuropathy persisted a little bit longer in the AVD plus brentuximab arm. In spite of this data, because of the cost of brentuximab, it's still not changed majority of our frontline treatment options. So based on this, we can conclude in advanced Hodgkin lymphoma, the interim PET has allowed us to risk stratify and both for the ABVD and if we are starting with the escalated BioCorp. But the most important information from the German Hodgkin 18 trial is that interim PET scan doesn't have the same prognostic ability if people are having the escalated BioCorp. The only information we can draw is if people are PET negative, they can have only 4 cycles of escalated BioCorp. And we do know, because of the 88% progression-free survival with escalated BioCorp at 5 years, escalated BioCorp is superior to the ABVD, but we need to accept more toxicity. And by using this ABVD escalated BioCorp with the interim PET scan, very small proportion of patients require involved field radiotherapy. There is encouraging data from the use of brentuximab, but its role still needs to be determined in the frontline setting. Having said this, where the brentuximab has made a significant difference is as an option for patient progressing following either the ABVD or AVD, with at least 20% of patients who are having brentuximab remaining complete remission at 5 years based on this extended follow-up of the pivotal study from Millennium Group. We also have a plethora of immune checkpoint inhibitors making a significant difference. We do have long-term data of both nivolumab and pembrolizumab, and what we do achieve by these immune checkpoint inhibitors is nivolumab is able to achieve nearly 90% overall response rate and over 25% complete remission, and pembrolizumab in similar group has achieved just under 70% overall response rate. And the most important is the median progression survival in patients who are responding to nivolumab is nearly 2 years. Moving on to peripheral T-cell lymphoma, in the last 5 years, because of the trial from the German group and also from the Nordic group, addition of etoposide to the CHOP has resulted in the progression-free survival advantage of PTCL, but the maximum benefit was to patients who are below the age of 60 and also the ALK group as compared to all other PTCL NOS. Unfortunately, this progression-free survival benefit did not translate into overall survival benefit. With this in background and based on what was achieved with the brentuximab in the Hodgkin lymphoma and in the ALCL, there was a frontline study conducted in over 452 patients where CHOP was compared to CHP replacing vincristine. And with this trial, with the median follow-up of 42 months, there was a doubling of the progression-free survival with 48 months with the ACHP as compared to 20 months with CHOP. And it is also resulted in the progression-free and overall survival benefit, suggesting that in the CD30 positive peripheral T-cell lymphoma, we may now have a practice-changing therapeutic option. On the subgroup analysis, it appears the major benefit in the PTCL does appear to be both for the ALK positive and the ALK negative group. When we are looking at this, we can also look at how the ALK negative ALCL now can be subcategorized, because we have two genetic markers. One is the DUS22 and a TP63. Based on this, we can identify three groups: the DUS22 positive ALCL, which has got almost similar outcome like the ALK positive ALCL, whereas the TP63 positive, the more poor prognostic group with survive 3 year and a 5 year survival of only 17%, whereas the triple negative which are negative for both ALK negative, DIS22 negative, and the TP63 negative, come in the middle with 43% chance of being a PFS and overall survival at 3 years and 5 years, so that we can use this information how to do the consolidative treatment in this cohort of patients. Moving on to follicular lymphoma, based on the initial data from Robert Marcus, we knew that adding rituximab to chemotherapy with the RCVP as compared to CVP, there is a progression-free survival advantage. Now, the question in the recent years has been which is the best anti-CD20 molecule. So this gallium study, we were able to look in over 1,200 patients with over 500 patients randomized between obinutuzumab and the rituximab. The obinutuzumab group had a progression-free survival advantage. As the chemotherapy backbone was not randomized, there is a definite advantage when with any of the chemotherapy in terms of the time for the next treatment. Only this information which is not supportive of widespread use of the obinutuzumab, if there is no overall survival advantage even after nearly a 5-year median follow-up. Either any difference or what is the practice changing in terms of the relapsed refractory follicular lymphoma? We do know about 20% of patients of follicular lymphoma do relapse within the 2 years, who have prognosis is significantly inferior. And we do have this augment and a magnified trial. In the augment trial, over 350 patients were randomized between lenalidomide and rituximab, where the treatment was for 12 months, and with a median follow-up of just over 2 years, there is over 2 years progression-free survival advantage for lenalidomide and rituximab as compared to rituximab alone. This progression-free survival advantage is also leading to the overall survival advantage, suggesting lenalidomide and rituximab is a very good therapeutic option in patients with relapsed refractory follicular lymphoma, particularly in patients who are relapsing within 2 years from their initial chemoimmunotherapy. Now, with so many exciting new small molecules coming into the CLL, we do need to ask the question, is FCR still the standard of care in patients with the CLL? Both in UK in the form of FLAIR clinical trial, and from the Alliance group, we have the E1912 study in which patients below the age of 70 have been randomized to receive either FCR or ibrutinib and rituximab, and the ibrutinib and rituximab was given for 6 months, followed by single agent ibrutinib. After a follow-up of nearly 34 months, what do we see is patients in the ibrutinib and rituximab arm, having not only progression-free survival, but an overall survival advantage, particularly in the unmutated CLL, whereas there was no progression-free survival advantage in the mutated. Based on this, what I conclude is if a frontline CLL patient have an mutated IGHV, then we should offer them the FCR because it is a time-limited 6 cycles, and a good majority of them are in remission at 5, 7, 10 years. Whereas for unmutated CLL, based on this data showing a significant progression-free and also overall survival, we have an opportunity to explore ibrutinib. Now, what about the CLL patient who are unfit for FCR? The gold standard used to be the chlorambucil, then we had the chlorambucil and rituximab, then chlorambucil obinutuzumab, but then we had a flurry of the small molecules, initially ibrutinib, subsequently venetoclax and obinutuzumab. Recently, we had this ELEVATE trial looking at acalabrutinib, which is a second-generation BTK inhibitor, looking with combination with obinutuzumab or acalabrutinib alone, compared to chlorambucil and obinutuzumab. In over 500 patients with a median follow-up of 34 months, we do see acalabrutinib with or without obinutuzumab having a significant progression-free survival, which at the minute has not translated into overall survival benefit. So something to look forward to. I conclude in the CLL setting with the current information, apart from the looking out for the 17p or p53 mutation, we do need to explore IGVH mutation status. And based on the IGVH mutation status, we could offer patients FCR if they're mutated, whereas for the unmutated patient, ibrutinib and or ibrutinib plus rituximab appears to be superior. Whereas for the unfit patients, now we do have an opportunity of using the small molecules, either the first or the second generation BTK inhibitor or venetoclax plus obinutuzumab. The advantage of venetoclax and obinutuzumab appears to be a defined period of 12 months. It is possible in the next few years we may be able to use a defined period of a BTK inhibitor plus a BCL2 inhibitor with a defined period of 18 months. This is for maybe an update next year when we do have the result of the GLOW study. With this, I will conclude.